Imagine a patient presenting with an asthma exacerbation, a slow-burning, persistent baseline condition that suddenly explodes into a violent, immediate crisis. As a medical coder, your operational challenge is to capture both realities. You have to translate that baseline persistence and the sudden onset into a standardized syntax that a payer system will accept. This specific clinical reality usually appears in the documentation under one very explicit phrase, a diagnosis labeled as both acute and chronic. Seeing those words together triggers a highly specific protocol, governed by ICD-10-CM guideline B.8. The core mandate of guideline B.8 is strict. When a physician documents a condition as both acute and chronic, you do not consolidate them. You must split the condition into two distinct codes. This requirement exists to enforce a strict hierarchy of clinical severity within the data string of the final claim. A coder's first instinct is often to hunt for efficiency, to find a single combination code that wraps both the acute and chronic states into one neat package. Yielding to that single code fallacy actively strips necessary detail from the patient's record, resulting in an incomplete picture of their health and the resources required to treat them. To apply guideline B.8 accurately, we will build the precise Boolean logic algorithm required to evaluate and sequence these overlapping diagnoses. Mastering this specific dual-code algorithm ensures you submit a precise, compliant claim, rather than triggering an immediate structural denial from a payer. The first absolute premise of this algorithm is that dual coding is strictly conditional. You can never automatically assume two codes are allowed just because a physician documented both words. Your first step is to take the documented diagnosis and cross-reference it within the ICD-10-CM alphabetic index. Looking at this simulated index page, your goal is to locate the main term for the condition, and then identify whether there are separate subentries for both acute and chronic. Finding the words is only half the check. The acute and chronic subentries must exist at the exact same typographic indentation level. If they don't align perfectly, if one is indented further, the dual code protocol is immediately aborted. Forcing two codes onto a claim when the alphabetic index structure does not actively support the split is a frequent error that leads to guaranteed claim failures. In scenarios where the index lacks that equal parallel structure, the algorithm routes you away from guideline B.8 entirely, requiring you to follow a different set of coding directives. But when the index does provide that valid parallel structure, the gate opens, allowing the two distinct alphanumeric codes to illuminate on the page. This visual verification in the index is mandatory. Regardless of your experience level, you cannot skip checking the physical indentation. The alphabetical index acts as a rigid, structural gatekeeper. It alone dictates whether a complex clinical reality can legally be split into two discrete pieces of data. Once you have extracted two valid codes from the indexed, you reach the second stage of the algorithm. You must establish their linear order. Take a look at this claim syntax string. It contains two prominent slots, the primary diagnosis and the secondary diagnosis. The position you choose explicitly dictates clinical priority to the payer. In this specific logic model, the acute or subacute code represents a condition with a sudden onset and short duration, the crisis requiring immediate, high-priority clinical intervention. The chronic code represents the baseline, a long-standing, persistent condition that is actively present but is not the immediate cause of the crisis. Guideline B.8 issues an immutable sequencing mandate for these cases. The acute code must universally occupy the primary sequence position. Consequently, the code for the chronic condition is subsequently relegated to the secondary position on the claim. To lock this sequence into your workflow, you can use the AMCI mnemonic MJ-GEM. Remember, fast comes first, long comes later. The clinical logic validating this rule is straightforward. The sudden acute manifestation is the condition driving the immediate consumption of medical resources, which justifies the patient encounter today. A frequent and fatal error occurs when a coder reverses this hierarchy, placing the chronic condition into the primary slot. When you sequence a chronic condition first, you are mathematically communicating to a clearinghouse that a stable baseline disease is the primary reason the patient required an emergency level of care. That logical mismatch tells the payer's computer system that the treatment does not match the severity of the primary diagnosis, triggering algorithmic claim rejections. When you are dealing with properly indexed parallel codes, acute leads is an operational absolute. There are no exceptions. Proper application of this sequencing hierarchy perfectly aligns the structural data of the claim with the actual clinical reality of the patient's immediate treatment needs. Identifying the two codes and setting them in the correct sequence does not mark the end of the algorithm. The final required step is to validate your sequence against the ICD-10-CM tabular list. You must check the space beneath the assigned alphanumeric codes. You are scanning this section for specific parameters, primarily excludes notes or instructional directives governing code pairings. The tabular list has final authority. Instructional notes found here hold the power to override your assumed sequences, or even prohibit specific code combinations altogether. Many coders skip this step out of overconfidence in what they found in the alphabetic index. Bypassing this final sanity check is a direct pathway to submitting an invalid code sequence and generating an avoidable denial. Without rigorous tabular validation, even a perfectly indexed and logically sequenced string remains an unverified high-risk assumption. Let's consolidate this workflow. When translating clinical documentation for overlapping acute and chronic states, your process begins by verifying that the documentation confirms both exist simultaneously. Next, consult the alphabetic index to ensure parallel, equally indented subentries for both terms. Finally, you validate against instructional notes in the tabular list and output the sequence acute leads, chronic follows. Rigidly following these steps guarantees you avoid the common pitfalls of single code assignments and reversed sequences. As you work, continually ask yourself 3 questions. Are both forms documented? Are separate index codes available? Is the acute code primary? Internalizing guideline B.8 elevates medical coding from basic data entry into the precise algorithmic translation of clinical pathophysiology.